Hello, I'm Dr. Gil Wilshire. I'm a reproductive endocrinologist. A reproductive endocrinologist is an OB/GYN physician who's done additional years of training to do infertility, female hormones, endocrinology, and special surgery as it pertains to female reproduction. You're probably here today because you have been having trouble having a baby. This is very, very common, and I'm very glad you're here. 91% of our patients wish they had actually come sooner. And we are a state-of-the-art treatment center. Our success rates are posted on the internet. Our reputation is very well established. And you can check this out on the internet if you wish. But our word of mouth is very gratifying, and we enjoy what our patients say about us. We are a state-of-the-art treatment center, like I said. But you get more than just me here. You get my team. We have a dozen professionals here who are involved in the entire treatment process, from the front desk to the labs, to the nurses, to the doctor that runs the lab, to the technologists, to our office staff, to our billing people, and our office managers. They are all keenly aware of the stress you're going through, and they all attempt to make this process as easy and as stress-free as possible. As I mentioned, a lot of people have trouble having a baby. For some couples, babies seem to come naturally and easily, but frequently that doesn't happen, and at least 1 in 7 couples has trouble having the children that they would like. Most people will be successful here. Proud of that. Our goal is to have you achieve a pregnancy safely, simply, and quickly, if at all possible. We have a very simple strategy, and that is to get some good eggs with some good sperm in a healthy uterus. Basically, it's as simple as that. Obviously, the devil's in the details. One of the common problems we have here in Missouri is that we frequently see very poor sperm numbers, even in outwardly healthy men. Our most recent numbers suggest that only 20% of men come in with completely normal semen parameters, but we have lots of workarounds for that and treatments, so it is rarely an insurmountable obstacle. Now, some basic information about human reproduction would be very, very helpful before you make any decisions. Some animals seem to get pregnant almost every time they mate. Humans, however, are very different. Even in the most ideal circumstances, human beings have about a 20% conception rate per cycle or per ovulation. And you can see from this graph that only 1 in 5 couples may become pregnant with their first cycle. But you may also interpret from this that we're rarely happy doing just one cycle. We'll frequently do a number of cycles, and you can see with each subsequent cycle the chance of getting pregnant on cycle 1 or cycle 2 or cycle 3 continues to go up. And in fact, if we've successfully overcome the obstacles in fertility, about half of our patients will be pregnant after 3 cycles. This mimics the normal fertility rate in young, healthy couples with no problems, and we accomplish this year in, year out. A very important second fact of human reproduction is that fertility in women, in particular, falls rather quickly with age. Women in their mid-20s may be at the most fertile point of their life, but after age 30, fertility tends to fall, and after age 35, it tends to fall very quickly. In fact, around age 40 on average, fertility is plummeting, and the average healthy woman who's trying to have children generally stops having children at around age 42. The news is even worse than that. Women after age 40, if they do become pregnant, will frequently miscarry as well. So age is not our friend, and it behooves us not to waste time if at all possible. Part of your initial evaluation will be to check to see if you actually have normal anatomy, or like I say, normal parts. You might think that of course I have normal parts, but in fact that's not necessarily the case. Up to 7% of women don't have normal parts, and this is something that can go unnoticed during previous evaluations. The female reproductive system is inherently inefficient, which accounts for our rather poor reproductive rates as a species. These two areas of inefficiency are located around the end of the tube and along the reproductive tract. When a woman makes a follicle cyst and releases an egg, that's called ovulation. After an egg ovulates, however, there's nothing that causes the egg to necessarily go down the fallopian tube. Other animals have a system where all the eggs go down the tube every time. We do not have this system. Obviously, if there's problems in the abdomen that prevent the egg from being picked up by the tube, if the tube is damaged, if the woman has something called endometriosis, or if there's blockage of the tube, then the egg will not necessarily get in the tube. One of our first strategies is to ensure ovulation. Get some idea if there's any obvious hindrance to the egg getting in the fallopian tube, and then make ovulation occur in a predictable, dependable way so that we can be fairly assured that eggs are, in fact, getting in the fallopian tubes. The second inefficiency in human reproduction is the ascent of sperm up into the fallopian tube. Like I say, sex is a lot of fun, but it's not very effective. If there's a low sperm count, if timing is an issue, if there are any anatomical abnormalities, then adequate sperm are generally not reaching the fallopian tubes where they would like to meet the egg and create an embryo. The solution for this problem is very straightforward. Since only 20% of the men in our practice have normal sperm counts, it is generally customary for men to get a semen analysis. We have facilities here that make the process private and convenient and as comfortable as possible. Virtually every man will get a semen analysis so we can see if there are adequate sperm to work with. I'd like to remind you that we don't need super high sperm numbers, but we do need adequate sperm. Now, I mentioned that we like to boost the sperm up into the vicinity of the fallopian tubes. This is done with a procedure called intrauterine insemination. Uterine insemination allows us to get the best sperm up into the fallopian tubes at exactly the time of ovulation. Timing is everything, and we are open most days of the week so we can optimize the timing of this insemination. I mentioned that we don't need super high sperm numbers, but we like to see at least 3 million swimmers, like we call them, in the insemination preparation, and that allows us to get very good success rates. All the processing is done here in our own lab. It undergoes a chain of custody process, so you can always be assured that the sperm you use are in fact the sperm that are yours. Intrauterine insemination is relatively inexpensive. It is absolutely painless, and we can fit this into your schedule during the day. Generally, you can do it over a coffee break or a lunch break, and the disruption to your life is minimal. For men and families that live close by, you can even produce the specimen at home and bring it in, as long as you get it here fairly quickly without it getting too hot or too cold. Generally, after insemination, the woman stays reclining for about 15 minutes and then is free to go about her normal activities. Part of today's evaluation will in fact include an ultrasound so that we can evaluate the status of the female reproductive system. As I mentioned, some women are born with an abnormal system, and we can generally see this with the ultrasound. Women as they get older, and women of some particular racial backgrounds are more likely to also grow abnormalities, or what I like to call troublemakers. Some obvious troublemakers are included in this slide. You can see a very common problem called uterine fibroids. Now, fibroids are not cancer. Frequently, they're not a problem. But I like to think about fibroids like we think about real estate. It's about location, location, location. A small fibroid in a bad location is generally bad. A fibroid on the outside of the uterus that doesn't impinge on the inside, the area that I call the promised land, generally can be left alone. Very common problem that women have. It seems that nowadays it's increasing. Endometriosis may occur in up to 15% of normal women without fertility problems. In our practice, at least 40% of women have endometriosis, and in many women it causes not just infertility, but pain. Part of your evaluation today will include an assessment to see if there's indications of endometriosis. Sometimes there's painful spots, sometimes there's painful nodules, sometimes we can even see endometriosis on ultrasound if it has developed a three-dimensional volume. During your examination, we'll be evaluating the entire pelvic floor and the reproductive organs. Nothing should hurt today. If something is painful, that may indicate endometriosis, scar tissue, or some other problem, and that will certainly be addressed in the remainder of your evaluation and treatment. It's important to realize, however, that an ultrasound and a pelvic examination do not necessarily determine what your problem is. We can determine most problems this way, but unfortunately the only way to really know what's going on in the pelvis is to do a surgery. Approximately 20 years ago, laparoscopy was done routinely on fertility evaluations on patients before they even underwent treatment. We don't do that anymore. Surgery is generally reserved for women with pain or with obvious problems. We like to avoid surgery if at all possible. It generally comes later in the fertility evaluation. If we do discover a problem and we recommend surgery, usually it will consist of what I call the bumper-to-bumper. The bumper-to-bumper involves a hysteroscopy that looks at the lower reproductive tract and the inside of the uterus, and a laparoscopy which looks at the upper reproductive tract, generally through the belly button. These procedures are almost always done as outpatients. At least 98 to 99% of women go home 2 hours later, and generally these women recover very quickly. Laparoscopy allows us to evaluate the reproductive organs, and it also allows us to treat them. We are prepared to treat virtually anything we find, and most women will leave surgery knowing what they have and what was accomplished to improve their fertility potential. Hopefully, if something painful was discovered, this can also be corrected at the same time. The large majority of our patients do not require very high technology treatments in order to achieve a pregnancy. Occasionally, women will have completely blocked fallopian tubes that are not repairable. Occasionally, a man will have such low sperm counts that we can't achieve enough sperm to do an effective insemination. For those infrequent couples, we can turn to high technology, and one of our specialties is in vitro fertilization. In vitro fertilization was invented over 30 years ago. It was originally designed to overcome blocked fallopian tubes. And after many fits and starts, the procedure was successful, and over the past decades it has been fine-tuned to become a very effective treatment modality. We achieve this because our team is excellent from the beginning to the end, and we leave no stone unturned to do the procedure properly and accurately. I'd like to emphasize that in vitro fertilization is generally the treatment of last resort. We only do IVF if we have exhausted other simpler, safer, and cheaper alternatives. During your evaluation, we will also be assessing the state of your general health. It turns out that a healthy woman has a higher chance of having a healthy baby. This is obviously intuitive, but science shows this to be true as well. We don't just want to establish a pregnancy here, we want you to have a healthy baby and be a healthy mom and have a healthy family. We frequently talk about numerous medical issues, and we'll do numerous things to improve your health if that's required. We frequently talk about optimizing a diet, We chat about nutrition, we talk about exercise, and we talk about getting you into the best shape possible so that you can optimize your chance of pregnancy. This allows you to get pregnant from simpler methods as well, and if we don't have to use high technology, this procedure can go quickly, and you can be on your way as quickly as possible. I don't deliver babies anymore, but I would like to send you back to your obstetrician with a very healthy early pregnancy that should hopefully go through the obstetrical milestones smoothly and without hassles. Our goal here at Mid-Missouri Reproductive Medicine and Surgery is to help you achieve the family that you desire. My wife and I have gone through this as well, and I can tell you the road is arduous, it can be long, it can be stressful, but it is worth it. Achieving a family is one of the greatest accomplishments in life, and if we can share that success with you, and if we can have the honor of participating in your care, it would mean an awful lot to me and my team. Thank you for coming to Mid-Missouri Reproductive Medicine and Surgery. I look forward to meeting you personally, and hopefully we can move through this process and get you on your way as soon as possible. Thank you very much.